Hello students, my name is Liz Attia and today's topic is principle-based ethics and non-maleficence. Okay, so principle-based ethics and non-maleficence. So as we mentioned in the week 1 lecture, non-maleficence is as the first concern doing no harm. And this requires that the practitioner refrains from any behaviour which may cause a patient any harm. Now, I just actually ask you to consider that for a moment. Is it possible as a change agent trying to promote the psychological and physical well-being of our clients and patients that no harm is actually caused? Is it by virtue of your role as actually being a change agent to try to actually push people beyond the boundaries of what's comfortable for them in terms of their physical progress and recovery, in terms of their psychological well-being, to test themselves and to challenge themselves around the boundaries of what is comfortable, and in doing so is harm implicit in that role. So can a practitioner, I guess is my question to you, really actually in complete observance of this principle of non-maleficence cause no harm to actually patients and clients? And if some harm is implicit in the role, what level then of harm is acceptable? So the non-maleficence principle requires a professional to avoid any deliberate act which may be detrimental to a patient, including, and this is where it becomes quite important, disregarding the wishes of the patient or having insufficient skills for treatment. Now, this becomes particularly important in the Dr. Patel case, which I'll draw your attention to, which is in the tutorial booklet. It's also to avoid emotional, physical, verbal or sexual abuse, which is quite straightforward, to refrain from treatment if the practitioner function is impaired, and there are cases in your textbook where this particular issue is noteworthy and should be considered, and clearly there's a dichotomy there, or there's there's an interrelationship between non-maleficence and medical negligence, because they are related concepts. So in terms, I guess, of how harm might occur, it might be in terms of an attitudinal attitudinal position. So it might be incompetence, it might be arrogance or an inability to consider other options. It might be an experience that the health professional actually brings to the relationship. It might be an overtly paternalistic attitude where it's, let me just do this for you, I can help you, listen to me, I know what I'm actually doing, disregarding the wishes and the intentions of the person. So the opposite of what we consider to be a person-centred approach. It might also be at an individual level. It might be an inability to communicate effectively or listen to patients, or to be attentive in your reflection of what people are saying, both in terms of content and in terms of emotion. It might be by making mistakes, repeated mistakes that border on negligence. It might be a personality conflict, such as intimidation or bullying, or a non-caring or nurturing persona. It might be a lack of concern for patients, so an indifference to what they're actually going through. All of these are examples of how harm is exhibited in practice. And if you actually look at many of the statistics around medical negligence cases, some of it is around technical competence, the ability of the practitioner or the professional to do their job properly. But a lot of it is this attitudinal and this communication stuff. So it's the manner in which people were actually dealt with, and the process by which the intervention was actually managed by the health professional. So don't underestimate the importance of managing relationships in terms of the importance of managing relationships effectively when you're dealing with patients and clients, because harm can come in all sorts of different ways. So the Dr. Patel and the Bundaberg hospitals, as well as the Dr. Reeves from the Bega Hospital, are two noteworthy cases, high profile cases where the idea of harm was actually talked about at great length in the medical negligence context. And I would refer you back to those particular cases in your tutorial case booklet to actually read the particulars of those cases and look at the commentary specifically as it related to Dr. Patel and the attitudinal behaviour which was demonstrated in his way of interacting with the team and the staff there at Bundaberg Hospital, as well as his patients, and how that contributed in the estimation of the patients as to the harm that was actually exhibited, not just clearly in terms of the technical skill and the medical procedures which were actually undertaken. So I guess in view of this particular principle and how it is actually rolled out in practice, the federal government declared that it wants to, and it has now, publicly released report cards on hospitals which go to disclosing information as to surgical success and error rates and infection. And there are some advantages and disadvantages of that report card approach. And I guess I'd ask you to consider that political context and how that might impact on the service delivery that happens behind closed doors. I mean, the attempt there is clearly to actually, in a spirit of transparency, give consumers the information that they require to be making decisions with respect to quality health care. But, you know, anecdotally, many who work within the system would actually report that there's a negative spin-off of that particular reporting system, where in fact, rather than having transparency, you're having lots of situations, well not lots, but situations of cover-up where the statistics and the data becomes very important and directs practice as opposed to what's in the best interests of clients directing practice. Okay, so some examples there in complementary alternative medicine, because it's an area that clearly is an evolving and changing area of health practice. There might be adverse reactions, for example, to herbs or to alternative medicines leading to poisoning. There might be unadulterated herbs leading to harm, adverse reactions to pharmaceuticals, misdiagnosis, failure to refer, failure to explain precautions, infections, for example, from acupuncture, physical injury, for example, from falling off a chiropractor's treatment table or the intervention itself, and even in a counselling context, this idea of transference, counter-transference, abandonment, if there's if boundaries in that therapeutic relationship become a little bit jaded or misguided. Thank you, students. That brings today's topic to an end.